So, a great time to be in. I think we have a huge number of options. We have come a long way in the lung cancer management. And now we are again in an enriched time with all the different options that have arisen and nuances that have developed and more to come. I see every time there is a new trial that results, we have more and more nuances to look at, and every patient has to be really looked at in a very detailed way so that we are doing the right thing. So as we go along and you look at the last decade, many new strategies coming, but these are the current strategy that we are going to talk about is definitely a path-breaking achievement in the lung cancer management field. And since we are in a Roche session, and the drug the drug in focus is Atezo. We talk about how Atezo happened in second-line setting and first-line setting through Empower 150, and then Empower 130 and 110, and now early lung cancer with the Empower 010, and approval in India as well. With that comes the question, how many of us are getting to see lung cancer in early stage? And I think, I'm sorry to have missed Bhuvan's talk, but we have early stage lung cancer that we see in our clinic, and this question was actually for Mistry sir, because he was going to be here, my surgeon, for the panel, but since he's not here, it's open to the Merong colleagues, and you can shoot. How many of us see, and what percentage are we seeing?
We have a surgeon. Dr. Priya is a surgeon.
I'm seriously making mistakes again and again. Serious apologies, please.
No, that's perfectly all right. Contrary to this data, if I see roughly around 30% of the patients who come to us are in some way operable out of the total number of lung cancer, and of the 30%, I would say early stage would be around 15 to 20% of that. That's a very small number, but 30% is roughly what we get, which is operable at some point of time.
30% is what you see in your in the patient population that you're seeing.
Yes, 30% operable at some point of time is either upfront or post neoadjuvant therapies. That's of the total amount.
Okay, and
I think down in the south it's lesser. I would say maybe around 20%, if not lesser, is actual patients. Majority are going to be inoperable. This is what we see down in the south.
Yesterday only George sir was there. So in TMH we see around 2,000 odd patients for lung cancer. Out of that, hardly 60 to 70 patients getting operated. So operable are very less. So early, if you say maybe around 10 to 15%.
Agreed. 10 to 15%. All cases in my center go through an MDT. So eventually, every case that comes, even if it's a metastatic setting, the surgeon and the radiation oncologist encounter those cases. So even in our data, it's somewhere around 10 to 15%, not more than that.
sure.
It is same. Due to COVID, there was some increase in early cancers because of COVID scans. Now again, it
Good
is
point. Yes.
coming down.
Rajat, same. So 10 to 15%, we started out with 30%, we went to 10 to 15%. Since I'm standing here, I'm not really in the panel, but I'll still put in my own experience. I feel ashamed that at my center, previously speaking, as well as now, I actually don't have exact answers. I don't. Whenever I sit in a stage 3 session and a neoadjuvant session and in an adjuvant session, if I'm supposed to give an exact percentage at my center, I don't have that. Because why? Because we do the ICMR registry. We did it at Kokila when we are starting out here. But if I go for a retrieval, we don't have methods for retrieval. Half of the registry's entries are not done. So many times when I sit in sessions and I'm supposed to tell how many patients are advanced stage and early stage, it's a guesswork. It's like a eeny, meeny, miny, moo. And it's a general feeling. So what's my general feeling? I hardly get to see adjuvants. And I ran Egan and Mermaid at Cook11, and we had deep trouble identifying patients. So that's a reality that I have faced. And we just saw some variations. I think Dr. Priya, being the surgeon and the gatekeeper, felt a little higher number. The rest of the colleagues felt a little lower number. We heard from Tata where we heard even lesser numbers.
So I think it's also because of where we all are working at, and they're all at different places. So Tata gets a bulk of 2,000 cases a year. How many people actually private hospitals or institutes get 2,000 a year? So the proportions which land up coming to a private institute are somewhat always skewed, right? So we might land up the patients who are metastatic will go doctor shopping and land up in XYZ place. Whereas if there's an institute which has a surgeon like Ramakant Deshpande, or if there's a team of thoracic surgeons, the patients who are operable, diagnosed somewhere else to be maybe operable, land up in that institute to get operated.
Very well said.
That's why it's skewed. It's very skewed data. One cannot
Very
rely
skewed
on Indian private institutes' data to be same as TMH data.
I agree. I completely agree, and actually reference here a recent publication review by Dr. Navneet Singh, where I went in to look at these numbers, and he quotes very well that in general, he would actually say that the early stage presentations are in the range of 5%, versus at tertiary centers where they are known to be operating centers, at centers where surgeons are concentrating. There, the numbers that are getting reported in the manuscripts are higher. So Tata is a place where the entire throng, public population, all lung cancer diagnoses are resulting, and we are seeing lesser numbers that are operable. And then surgeons that are known countrywide to be leaders in surgical approach, and there probably earlier patients are reaching. So variable numbers. Having said that, in this, it is demonstrative that stage 1 to 3, there are patients worldwide that are making it into clinics at stage 1 to 3, and we need to wake up to diagnose our patients sooner. So if a patient were to present with early stage lung cancer, what is our general approach? What are the centers doing? How are we practicing? Do we have a multidisciplinary tumor board where we are discussing? And I'll ask Dr. Rajit to start from that side.
So as mentioned, that it obviously depends on center to center. So at my center, so I don't think that we get more than 5% patients who are able to undergo surgery for lung cancer. So yes, it's obviously discussed in the tumor board, and after that the decision is taken. So, there is a tendency for surgeon to push for neoadjuvant chemotherapy when they are in doubt. So most of the time that turns out to be CTRT. So this is the advantage and disadvantage also of the tumor board.
Because you have an opinionated presence in the MDT. Rishabh?
I would agree that tumor board is necessary, especially for locally advanced disease. And most of our patients do undergo discussion, may not be the formal tumor boards, but most of them talk to surgeons and medical oncologists and radiation oncologists and then decide of the treatment. Surgeons are more comfortable now with neoadjuvant approach than adjuvant approach.
Neoadjuvant approach than adjuvant approach.
They are generally sending the patients, even if operable, they will send. And most of our patients are more of 2-3A than 1B kind of thing. So guidelines wise also they should ideally receive neoadjuvant. So that is the case in my center.
Sure.
Yeah. So in our center, if it's an early stage, we usually have medical, surgical and radiation oncologist in our tumor boards. But if we encounter an early stage, we also rope in a pulmonologist, because it's very vital for us to move ahead. Without a pulmonologist, without staging the mediastinum, we don't take any decisions. So there's one other person who usually enters our tumor board if it's an early stage lung cancer. And after our pulmonologist stages a mediastinum, that's where decisions of neoadjuvant or adjuvant are taken in my practice. Yeah.
So excellent. I think we've seen some consistency in the patterns that we are discussing amongst our colleagues. We're coming to a joint decision. We also heard that there could be some skewed recommendations because of the larger presence and a particular mindset, and that is always the case. I think surgical heavy centers, radiation heavy centers, and this is across the world. I would say management practices vary depending on where you're presenting your case and what's the larger presence. And even, yes, please.
One of the issues in our hospital is we have a thoracic surgeon, non-oncological, and we have an oncosurgeon. So it depends where the patient lands up first. If they reach the thoracic surgeon, even for probably even some of the N2 diseases, upfront surgery is done and then sent to us. So we end up with more adjuvant since the doctor is more popular. In our oncosurgeon, if he comes, it comes through our tumor board discussion. So we've tried to breach this barrier, but when seniority is there, it's kind of difficult.
Yeah.
That's the issues that we've faced in our hospital.
That's such a great observation, because this is a reality all across the world. I'm just going to reflect on that in a second. Dr. Ajay?
In our center also, maybe hardly 5 to 7% we are seeing getting referral for the neoadjuvant.
Yeah. And before I come to Dr. Priya to get the final word on this, I will ask the group again, what do you give for neoadjuvant? What are you giving? Are you giving Checkmate 816?
This data has come for chemoimmunotherapy. So I think now, we are also now, surgeons are comfortable for sending for the chemoimmunotherapy because
So you are doing chemoimmunotherapy?
Yes, ma'am.
And standard of care, anyone has a trial open out here? Yeah. So we are practicing chemoimmunotherapy. Yeah, at least we are discussing. No? Yes? Not really?
It's okay, not yet.
Not yet?
But yeah, after this, probably yes. But we haven't started yet. We've got
So
more patients.
aware,
Yeah.
wanting to go there, but not there
Yes,
yet.
I think since the data is out, I've not had a patient for neoadjuvant. I
Yes.
think that's probably the reason.
Right.
Once we get the patient, yes, I think that
You
we
would
should
discuss.
Yes,
Yeah.
discuss.
Yeah.
So we should be aware, but we should not jump to chemo-immuno combination without having the background NGS and all that important driver mutation report before.
So
planning.
we had
Great
one
talk.
patient.
So if we are following the, means any methods, we are following the guidelines after testing the EGFR.
So in practice, when the last patient we had probably was a month back, when he had a single station N2 and had a 6 centimeter lung lesion. So in this patient, we were having this discussion of going for neoadjuvant IO plus chemo. The basic issue which we faced was doing a biopsy, sending it for NGS. The turnaround time was 3 weeks in my practice, and that was not acceptable by the patient. So we ended up explaining him that the standard is still either chemoradiation or neoadjuvant immunochemo. Patient was not keen on either. So we ended up operating. It was fortunately a single station and even post-operative setting, and now is on adjuvant chemotherapy. Started last week. Again, the problem with neoadjuvant immunochemo, at least in my practice, when I decide, is having an NGS report in hand. So I'm not comfortable otherwise. Without an NGS, if it's just EGFR and ALK negative, I'm not keen on starting chemoimmuno unless I'm sure that the other mutations are negative.
Okay. I think these thoughts are evolving, and it's interesting to see how we are approaching.
So I think there's a practical solution is that you can add from the second cycle.
I think
have 3 cycles.
no,
You need to give adjuvant also.
the NGS hotspot panel now takes 7 days from core diagnostics.
Where
So
we send is 3 weeks.
okay.
We do the Illumina
Yeah. So, Dr. Priya.
Ma'am, what do you prefer? As per means the trial, it is
Good question.
It's EGFR ALK they have excluded. So you will do EGFR ALK by RT and ISC, RT-PCR ISC, or you will prefer NGS?
So I would say it's a dilemma. Reason being, if you look at all across, now we have started realizing that driver mutations don't do well with immunotherapy, right? But if you look at these trials that are resulting, including the trial in question, the exclusions are only with very limited exclusions are there. And actually, this trial did not exclude. So you have post-trial analysis for most of the data, starting from Pacific and coming backward. So what do we practice? If I did not have an EGFR ALK-ROS patient, then I would look at adding, even if the NGS is cooking. That's been my...
That is what I'm saying, ALK-ROS, EGFR ALK, And the remaining KRAS or BRAF, again it is a sensitive. If you excluded L-cross, and we know the majority chances it may be KRAS or maybe BRAF. And remaining all are very rare. So is it very necessary to wait for NGS?
So in my clinical practice, I have not waited for the NGS to result before the neoadjuvant approach, but it was interesting to see all these angles play out, and I think we don't have a perfect answer as of today, and all these nuances are going to play out in the later time. At the current time, I think we are operating with these applications, not even testing. In India, we have to test even at least the basics, the large representation of driver mutations, because we have larger numbers than the Caucasian population can speak of. So that has been my approach, and that is how I would approach any patient at this juncture. But yes.
So before this session, we had low-dose IO session. So, Roche does not have they have a fixed 1200 mg. So nivolumab, we are comfortable using 40 mg. So if given a choice, given neoadjuvant and adjuvant setting, probably I think things will be more towards nivolumab 40 mg, because we can maybe easily add to the neoadjuvant setting and later on adjuvant. So I know this is a Roche session, but still nivolumab has that option.
So I have been a lifelong researcher. And in that, I would say we really need to look at the approvals and the application. In the current setup, the way we are talking adjuvant. This is the drug that is approved for this particular finding, and that is how it has to be given. If you follow the guidelines, one would want to give it this way.
But
I think
for that, patient has to be according to that trial only, no? But we don't get patients according to that trial.
Right. So my question there, and actually, since I'm moderating the session, I'm not supposed to be asking questions, but I'll still put it up there, and asking questions in general. Do we know that the 40 milligram in an adjuvant setting will add to anything in lung cancer patients with those features? So I just wish to leave it for later. Did we cut my time? Okay. All right. So I think the meat of the discussion is still pending. So I'll deep dive because there's limited time. PD-L1 testing. Are you all doing PD-L1 testing in early stage patients?
At my center, we usually start with NGS, and then if it is mutant negative, we do PD-L1, we do the 2 to C3 deco platform at our center.
And?
Yeah, we use a 12 gene hotspot, which includes a PD-L1 thing, so it comes as one report, and we do SP263 in that.
Most of us have SP263, right? So this sits in very well. And Priya, do you do testing? And have you been practicing it in the past as well? Yes. So you came into this informed, actually, about the PD-L1 positives and the negatives. And then comes the trial where we have DFS advantage with the background that if we were to not apply the DFS and go in for only OS in an adjuvant setting, this is the lag time that there exists following the previous studies that have been presented and followed for adjuvant application. So the groups take on applying this in terms of the DFS advantage that we already saw. Do you think that that is enough for you to apply to the patient population, and which patient population would you apply this to?
My practice very confidently for patients with PD-L1 more than 50%, I would apply the Atezolizumab data. Anything less than that, I'm still not sure if I'm there to accept that as a good enough endpoint.
Apart from this, smoking status also makes a difference. PD-L1 more than 50, and probably if the patient is a smoker, I will be more comfortable.
So for you, the all-comer PD-L1 positive doesn't work. You want it way above 50%, and you'll cross your T's by looking at who was a smoker, who was not, what's the possibility of this patient to be benefiting from the drug.
Because we are probably asking a patient to spend almost all his savings. So we need to be very sure that whatever we are offering, at least we are comfortable to offer that drug to the patient. So that's why I think till the time we have the final OS data, we need to look at, we need to give that drug in those subsets only where there is definite proven benefit.
And in the PD-L1 1 to 49%, anyways the hazard ratio is crossing 1. Probably the benefit is not that great.
Even the updated OS for PD-L1 more than 50% was something which is a little pushing us to consider, but less than 50% I'm not really sure. Even the EM approval probably is only for more than 50%. So,
Right. So there are different approvals. Yes, Rushabh, please.
From the traditional teaching, we were always waiting for OS to come. We have shifted to DFS so that our patients get the benefit. The DFS would appeal me if the hazard ratio is significantly down. 0.8s and 0.9s and 0.7s are something, especially if confidence interval is crossing 1, is something which we should be aware of. We have not changed, we are not giving first generation TKI to everyone with DFS benefit. But with ADAURA, we had that DFS of 0.17, 0.23, and that was something which pushes us that it is likely to convert into OS benefit, and hence we are now thinking of.
So 0.43 is good for everyone?
That is the best we have at this point of time, and it is reasonably good. So we have to discuss with the
that is
patient.
an outlier here?
We don't even know that the ADAURA will eventually show OS. If you see the recent presentation in the ESMO 22, the updated data of the OS, the curves are coming down. So we may not end up getting OS benefit with ADAURA also.
Would you go for the DFS if the OS does not happen? Provocative question. Would you go for the DFS if the OS does not happen?
No,
No.
not in a adjuvant setting, definitely.
So that's a question mark. That'll play out in 10 years, right? So till then, you don't know. So in the interim, there is an OS, a trend to OS benefit that we know of, right?
So I think in these cancers where
Getting
the
done.
population
Last
is very low, we have very few patients in clinical practice and in clinical trials. If something is given, is going towards that trend of OS, then we should probably use it in clinical practice. If the subgroup is also showing that it will benefit in those patients who have PD-L1 more than 50, so I don't think there should be a doubt, because we'll not get such kind of studies very often.
So this is a drug that we all know from our previous experiences that this is a well-tolerated drug, right? If we have to keep the cost center stage, then of course all the nuances come in, and we have to contemplate and look at what can be given, what cannot be given. There's also the circulating tumor DNA. I don't know how many of us are doing ctDNA tracking for our patients, for adjuvant patients. Are we doing ctDNA tracking? Okay, so I'm doing, but we have multiple different layers of adjuvant application now, where we are looking at biomarker-driven adjuvant application. We have a PD-L1 above 1% approval, but we all spoke here that we are looking at above 50% and that we are looking at the largest benefit as an application. So final word from all of you all in terms of applying Atezo.
I would just ask you a question, because that's something which I'm not doing in my practice. I don't know how many else are doing ctDNA as a monitoring tool. Are we doing ctDNA to monitor, or are we doing an MRD analysis? Because that's very specific. Because ctDNA probably in adjuvant space, I don't know.
Very good question. Very good question and very well put. And actually, if you're asking me, it's MRD. It's MRD tracking. But even from a ctDNA perspective, there is emerging data, tumor-informed, tumor-uninformed, that even the tumor-uninformed is reflective. We have to really take it with caution here, because there are emerging labs coming in locally where we have to really understand, especially in adjuvant setting, whether it's translating into the same results as we saw here. Until that happens, one can't use it as a standard of care practice. Coming back to the slide in question, So we have agreed about the above 50%. We also heard from Dr. Mole about OS not being met at a later date and whether that would be something that will be playing on your mind if you were to take a final decision today. But if you had a patient in hand who has a history of smoking, who has high PD-L1, and who is negative for the driver mutations, although the study did not exclude essentially, would you look at the patient for Atezo, and would you absolutely make sure that this patient was driver mutation negative?
I think definitely patient should be driver mutation negative. So that is the utmost criteria of giving any IO in whatever setting we are planning to give. And I think this criteria is good enough for me to start Tecentriq maintenance in first line if the PD-L1 is more than 50. And smoking history also gives the confidence that you can start this patient as maintenance. So DFS is good enough endpoint considering that the rarity of the disease that we are dealing with.
Thank you. I think that is the bottom line. Anyone else wishing to say anything, rapid fire, because we are at the end of the...
Should I make a conclusion? We will follow the IFR 010 in our clinical practice.
Sure. Excellent.
Do whatever, send the patient to me.
But the patient is going to be sent by you to us. You know, you're going to tell the patient.
You adjourn and give it back to me.
So I'll tell you why we have Priya out here, right? We have Priya out here, and we had Mistry sir out here. He didn't make it because they need to be aware, because they are the gatekeepers. If they don't tell the patient, listen, after your chemotherapy, you're going to get Atezo, patient is going to say, I'm not going to go to the medical oncologist. So I think the most important people in this are the gatekeepers, that are the surgeons, where the stage is set for what's going to happen. So I've always said this. I said this at the time of Pacific. I'm saying this now. We need to be aware of what the applications are, and the gatekeepers need to make the patient aware of what the situations could be. Just from Egan and Mermaid, the rules are actually different for the application. We as treating oncologists will be doing the driver mutations. We as treating oncologists will be looking at the PD-L1, and we will be looking at the smoking status, because that becomes, that is center stage into application for a drug that is so expensive and has to be worth the money. So thank you so much. And
Last question, ma'am.
Yes, please.
Suppose a patient come. Sir, एक last question is.
We'll discuss. Ajay will discuss it outside. Don't worry. Don't worry. Thank you so much. Thank you, and sorry for making it late to the session. I hope I made it interesting. Thank you again.